Have you ever stopped to think, really think, about how we know if these huge public health programs, the ones meant to help millions, are actually doing what they're supposed to?
Yeah, beyond the headlines and the policy papers, how do you measure the real impact?
Exactly. So today, we're putting on our detective hats, you could say. We're diving deep into a really important puzzle, Brazil's massive effort to transform its primary health care.
And specifically, how researchers came up with a rapid assessment methodology to try and get a genuine measure of its effectiveness.
Our guide for this is a really fascinating research paper from 2007. It's by Macinko, Almeida, and de Sá, looking right at primary care in Brazil.
Mm-hmm.
So our mission today, let's unpack this clever method. Let's understand what it actually showed about Brazil's big family health program, the PSF, especially compared to the more traditional
Got to
services.
figure out what lessons that holds, right, for
Mhm.
improving healthcare, not just in Brazil, but potentially in developing countries everywhere. And it's such a critical mission because primary care, fundamentally, it is the backbone of a good health system. It's supposed to be.
Right. Your first stop.
Yeah, it's where most people connect with healthcare first, right? For checkups, managing long-term conditions, preventative stuff. But well, the reality is it's often the weak link in the chain.
Under-resourced, maybe?
Hmm.
Or just not set up effectively?
Could be either or both. And in systems that are changing fast, like many developing countries trying new things, having a solid way to evaluate
Mm.
to see if these changes are actually helping people. It's not just nice to have, it's absolutely vital.
Okay, so let's set the scene a bit. To really get this, we need to go back to Brazil's big health reforms, starting way back in the 1980s.
A really pivotal moment.
Yeah, a huge shift happened with their 1988 constitution.
Yeah.
It basically declared health as a universal social right, a citizen's right, and a government's responsibility.
That laid the foundation for everything that followed. It established the unified health system,
Yeah.
the Sistema Único de Saúde, or SUS.
Oh, so okay.
And the heart of SUS really is built on these two big ideas: equity and universality. Everyone gets access, regardless of, how much money they have or where they live.
So for most Brazilians, primary care means going to their local public health post.
Generally, yes. But by the mid-90s, Brazil realized they needed a more proactive strategy to make sure primary care was really effective and reaching everyone. And that's where the Family Health Program, the PSF, came in.
Ah, the PSF, Programa Saúde Família.
Exactly. And what made it so different, so innovative, was its structure. It wasn't about just waiting for sick people to turn up.
Right.
It sends out dedicated teams, usually a doctor, a nurse, and several community health workers into the neighborhoods.
So they're visiting people at home regularly.
Regularly, yes,
Okay.
within a specific geographic area. The goals were, well, pretty ambitious. First, make primary care the real gatekeeper.
Meaning your first point of contact, guiding you if you need, say, a specialist.
Precisely. And also, to integrate different services, shift the focus from just treating one person's illness to caring for the whole family unit.
Okay, that makes sense. Thinking about the family context.
And, crucially, boosting community involvement and outreach, really connecting the clinic to the community it serves.
And the scale you mentioned, it's kind of staggering. By 2006, the PSF covered 85 million people.
85 million, almost 45% of the entire population of Brazil at the time.
Wow. So you're talking about one of the biggest community-based primary care systems anywhere in the developing world.
Absolutely. But here's the catch, the reason for the study we're looking at. Despite this huge scale and ambition, there was a gap.
Okay.
There wasn't a standard tested way to measure how well it was actually performing at the local clinic level. Lots of anecdotes, maybe, but no consistent data.
Ah, so this study was about creating that tool, moving from guesswork to actual evidence.
Exactly that. To design and validate a tool to fill that specific void. And crucially, one based on user experience.
Right, what the patients thought.
What the users were experiencing. Because, policymakers might have one view, providers another, but what do the people receiving the care actually perceive? That's powerful data.
So tell us about the study itself. Where did they do it?
They focused on Petrópolis. It's a city, a municipality, about 2 hours' drive from Rio de Janeiro.
And why Petrópolis?
Good question. It was sort of a perfect storm in a good way. It had a large, diverse population, which is good for testing. It was also one of the places that adopted the PSF quite early on.
Okay, so they had experience with the program.
Right. And importantly, the local health leadership, the secretariat, they were actually open to being evaluated. They wanted to know how things were going. That collaboration is key for this kind of research.
Makes sense. You need buy-in. So how do they actually go about measuring something as, well, as complex as a healthcare experience?
They adapted an existing internationally respected tool called the Primary Care Assessment Tool, or PSAT.
PSAT, okay.
It's designed to measure these essential dimensions of primary care, 8 of them in the standard tool.
8 dimensions. Can you give us a feel for what those are? Like, what sort of things does it measure?
Sure. It looks at things like access. Pretty fundamental. Is it easy to get care when you need it? Can you get an appointment reasonable quickly?
Right.
Then gatekeeping. We mentioned that is the clinic your first port of call, guiding you through the wider health system. Longitudinality. That's about seeing the same provider over time, building that relationship, that trust. It's incredibly important.
Continuity of care, basically.
Exactly. Then comprehensiveness. Does the clinic offer a broad range of services? Vaccinations, chronic disease care, maybe even basic mental health support.
So not just treating coughs and colds.
Right. Coordination is another. If you do need a specialist, does your primary team handle the referral smoothly? Do they share information effectively?
Avoids you having to tell your story over and over again.
Hopefully. Then family focus. Do they see you as part of a family? Consider that context. And community orientation. How well does the clinic understand and respond to the specific health needs of its local area?
Okay, that's quite comprehensive in itself.
It is. And for Brazil, they actually added one more scale specifically about the providers.
Tailoring it to the local context.
Precisely. So armed with this adapted PCI, they surveyed users.
How many people did they talk to?
They randomly selected 468 adult users from 40 different government primary care clinics in Petrópolis.
And were these all PSF clinics?
No, that's key. It was a mix. 25 were PSF clinics and 15 were the more traditional service clinics. So they could compare.
Got it. And how did the users respond?
They used a scale from 0 for never up to 5 for always for various questions related to those dimensions, like, is it easy to get an appointment here, or does the provider treat you like a whole person?
But you mentioned they did something clever with the responses.
Yeah, this is interesting. Instead of just using the average scores on that 0 to 5 scale, they simplified it. They dichotomized the answers, basically turned them into yes or no categories for analysis.
Why do that?
It helps minimize potential response bias. You know how some people might just tend to always rate things in the middle or always high? This forces a clearer distinction and can give sharper results for a comparison.
Okay, less ambiguity.
Exactly. And again, the focus wasn't just general satisfaction. That word can mean so many different things to different people, and it's hard to pin down.
Right. Subjective.
Very. They wanted to measure specific aspects of the care received. Much more concrete, much more actionable if you're trying to improve things.
And they compared this user data to provider data.
Yes, they had results from an earlier pilot study where they'd asked providers in the same clinics similar questions, so they could directly compare. Do the people giving the care and the people receiving it see things the same way?
Fascinating. Okay, so after collecting all this data, talking to nearly 500 users, what did they find out? Who are these users, first off?
Well, the demographics showed the users were mostly women, about 82%.
That's quite common in primary care usage, isn't it?
It often is, yeah. The average age was around 40. Education levels were generally quite low. 3/4 hadn't finished primary school.
Okay.
And while most had, basic things like electricity and water, other indicators suggested lower socioeconomic status. Like only about 2/3 had a telephone, only 1/4 owned a car.
And critically, were the users of the PSF clinics different from users of the traditional clinics in terms of these demographics?
No, and that's really important for the comparison. The study found no significant differences in demographics or even self-reported health status between the two groups.
So comparing like with like, essentially.
As much as possible, yes. It strengthens the findings about the type of service.
Okay, so let's get to the core findings. PSF versus traditional. What did the users say?
Well, the headline finding is pretty clear. Overall, users of the PSF clinics reported a significantly better primary care experience.
Significantly better.
Statistically significant, yes. The average score on their scale was about 0.76 for PSF users compared to 0.63 for traditional service users.
So roughly a 20% higher assessment. That sounds substantial.
It is. It's a pretty strong endorsement quantitatively of the PSF model from the user perspective.
And did that hold true across all those dimensions you mentioned earlier?
Not quite everywhere, but PSF significantly outperformed traditional services on 4 key dimensions. Remember those?
Let's see, gatekeeping.
Yep, gatekeeping. PSF was seen as doing a better job of being that first point of contact.
Comprehensiveness, offering more services.
Exactly. Comprehensiveness was another win for PSF. Also family focus, considering the patient and their family context.
Okay.
And fourth was community orientation, being more responsive to local needs, better community engagement.
So gatekeeping, comprehensiveness, family focus, community orientation, PSF, significantly better on those 4. Or what about the others? Access.
Access, that was the big exception. Both types of clinics, PSF and traditional, scored poorly on access.
So even though PSF was better structured in many ways, actually getting through the door, getting an appointment remained a challenge everywhere.
That's what the user data suggests, yes. A shared weakness.
But here's something you mentioned earlier that really caught my attention. The variation within the types. It wasn't just PSF good, traditional bad.
Not at all. And this, I think, is one of the most interesting parts for anyone involved in healthcare delivery. When you look at the graphs showing scores for individual clinics, yes, on average, PSF was higher. But you saw some traditional clinics scoring as high or even higher than the lowest performing PSF clinics. And you saw some PSF clinics like number 16 and 17 in their chart that were just miles ahead, exceptional scores.
So what does that tell you? It's not just the model, is it?
Exactly. It strongly suggests that how the program is implemented matters hugely. The leadership within a clinic, the team dynamics, the local management, something within those high-performing clinics, whether PSF or traditional, was making a big difference.
It's about execution, not just the blueprint. You can have a great model, but if it's not run well.
Precisely. It highlights the potential for quality improvement within the system, learning from those positive outliers. What were PSF 16 and 17 doing so right?
Did they dig into that further? Like what predicted these higher scores?
They did some more complex analysis, multivariable regression to try and tease that out, and it got even more nuanced.
Sure.
When they controlled for various factors, simply being a PSF clinic wasn't the strongest predictor anymore. What was significant? Well, how healthy people felt they were.
Self-perceived health status.
Yes. People who reported better health were almost 1.7 times more likely to give their primary care a higher score.
Interesting. Maybe they just needed less from the system.
Possibly. Or perhaps healthier people have more positive interactions generally. But the most significant predictor, it was the specific clinic the person attended.
Back to the variation again, the individual clinic code.
Exactly. More so than whether it was broadly classified as PSF or traditional. It really brings home that question. Is it the overarching program design or the nitty-gritty of how that specific clinic operates that truly drives the quality people experience?
It suggests the implementation, the local factors, are incredibly powerful.
Immensely powerful. And remember that comparison between user and provider views.
Right. Did they agree?
Overall, on the total score, they were pretty similar. But there were a couple of interesting disagreements on specific dimensions. Users actually rated gatekeeping higher than providers did.
Oh, so users felt the clinics were doing a better job as the first point of contact than the providers themselves thought.
Seems so, but conversely, users rated family focus lower than providers did.
So providers thought they were doing a better job of considering the family context than the users felt they were receiving.
That's the gap suggested by the data, little perception differences that could be really important for communication and service design.
Yeah, definitely food for thought there. Okay, so we have this tool, the Adapted PC app. How reliable did it turn out to be? Was it actually a good measuring stick?
The evidence suggests it was, yes. Very reliable and valid. The overall primary care score showed good internal consistency. What researchers call Cronbach's alpha was 0.80, which is strong. It means the different parts of the questionnaire were measuring the same underlying concept effectively.
And you mentioned it didn't seem biased by demographics.
Correct. Crucially, the scores didn't really change based on the user's age, gender, wealth, or education level. That's a big plus. It suggests the tool was genuinely measuring the care experience itself, not just reflecting the characteristics of the person answering.
That gives you confidence in the results across different groups.
It does. It suggests it's a robust tool for diverse populations.
And practically speaking, was it easy to use? You called it a rapid assessment.
It lived up to the name. Less than 20 minutes to administer one questionnaire, and sampling users at a clinic, they could do that in just 1 or 2 days.
That's pretty efficient.
Very. And importantly, the health managers in Petrópolis, the people who would actually use this information, they found the results easy to understand and Critically, actionable.
Actionable how?
They could see clear results for their specific clinic and for the district overall. It gave them concrete data to guide improvements, to see where they were strong and where they needed to focus efforts. It wasn't just abstract research, it was a practical management tool.
That bridge between research and practice is often missing.
It is, and this study seems to have built that bridge quite effectively in this context.
Now, you mentioned limitations earlier. Every study has them. What were the main ones here?
Well, a key one is that it didn't measure the technical quality of the clinical care.
Meaning, like, was the diagnosis correct? Was the treatment appropriate according to medical standards?
Exactly. It measured the organization and experience of care, but not the clinical correctness. So we can't directly say from this study that better user scores equal better health outcomes, although other research often links those.
Okay, fair point.
Yeah.
What else?
The results are specific to Petrópolis. While the method is adaptable, you can't automatically assume the exact same scores or patterns would appear in every other city in Brazil. Context matters.
Sure. Generalizability is always a question.
Right. It also didn't look at things like the geographic distribution of services were clinics located equitably, and it didn't include people who don't use the primary care system.
Non-users. Could that bias the results? Maybe only the relatively satisfied people use the clinics.
It's a potential bias in many health surveys, though in Brazil's universal system, SUS, the idea is everyone should have access, which might lessen that bias compared to other countries. But yes, it's a limitation they acknowledge.
Understood. But even with those limitations, the broader potential seems quite significant.
I think so. This provides a validated, practical way to assess comprehensive primary care, especially in developing countries where such tools are often lacking.
And we know from studies elsewhere, usually in wealthier countries, that strong primary care is linked to better health, lower costs.
Exactly. Better quality, better equity, often too. This tool could help developing countries gather that same kind of crucial evidence for their own systems to make the case for investing in and improving primary care.
And making it freely available is a huge step.
Absolutely. The fact that the Portuguese instruments, even software for analysis, were made available freely via the Pan-American Health Organization, that really aims to get the tool used more widely.
Okay, so let's try and synthesize this. We've gone through the context, the method, the findings.
Mm-hmm.
What are the main takeaways for you listening to this deep dive?
Well, first, Brazil's big bet on the Family Health Program, the PSF, seems to have paid off in many ways, according to users. It improved key aspects like being a proper gatekeeper, offering comprehensive care, and focusing on families and communities.
But not a magic bullet. Access was still a problem across the board.
Right. Room for improvement, especially on access. Second, the study gives us this validated, practical tool, the adapted PSET, that can genuinely measure user experience. That's incredibly valuable.
And third, maybe the most intriguing part, is that variation. The reminder that national programs are important, but quality often lives or dies based on implementation at the very local, individual clinic level. Leadership matters. Teamwork matters.
Absolutely. It's not just the model, it's the execution.
So it offers both a way to measure and insights into what drives better performance.
Which leads us to a final thought, something provocative perhaps for you to consider. The study itself points this out. Having a great tool like this is essential, but it's not enough on its own.
Just because you can measure something doesn't mean it automatically improves.
Right. At the time of the study, the financial incentives for municipalities in Brazil were mostly tied to just increasing the number of people covered by PSF, expanding coverage.
Not necessarily linked to the quality of the care being delivered.
Not directly, no.
Yeah.
So the big question this leaves us with, relevant far beyond Brazil, is this. How can health systems integrate these kinds of robust assessment tools with incentives that genuinely drive improvements in the quality and the outcomes of care?
Moving beyond just counting heads covered to actually rewarding better care experiences and ultimately better health.
Exactly. What kind of incentives, financial or otherwise, do you think would actually work? How do you motivate sustained quality improvement in primary health care, making sure these programs truly deliver on their promise?
That's a really critical question, something to definitely mull over.